Hi, I'm Sumit Gupta. I'm a fellow at Brigham and Women's Hospital in Boston. I have Dr. Min with me, who is past president of FSCCT and currently the new editor-in-chief of JCCT. And I will be asking him a few questions. So welcome, Dr. Min.
Thank you for having me.
Thank you for being with us. And is that okay if we start with a few questions?
Yes, of course.
So the cardiac CT is on the rise, and what are your thoughts on how it can be used as a preventive tool?
Is it on the rise?
It's definitely on the rise.
I think since the introduction of 64-slice CT in 2005, it's been, I think, a long uphill battle to try to develop the sufficient scientific evidence to support its use. Mm-hmm. I think that in the last 10 years, we've seen it certainly has substantiated its use in the assessment of patients who present symptomatically with stable chest pain or with acute chest pain. Where it fits in the prevention realm, I think, is still yet to be decided. Certainly, I think that coronary artery calcium scoring, non-contrast CT, has a great role in screening patients who are sort of in that unknown category and can help make decisions or guide decisions based on their findings. Coronary CT angiography, I think probably there still needs to be a fair amount of evidence generation.
Okay, thank you. So kind of a second follow-up question with this is, what are your thoughts on how CT can help us in plaque imaging more than just identifying calcified and non-calcified plaque?
Yeah, I think to me that's the most powerful part of coronary CT angiography.
Okay.
We've never had a tool that has allowed us to do whole heart, 3-vessel characterization of atherosclerosis and quantification of atherosclerosis. We've had intravascular ultrasound, which again has all of its sort of biases of, you can only do a few people who are willing to undergo invasive procedures. It's generally limited to single vessels. So where CT, I think, really adds is in that whole atherosclerosis assessment. Mm-hmm. And the reason I think it's so important is because we've always studied the consequences of disease, not the actual disease, right? So if you think about it, stenosis is an anatomic consequence of atherosclerosis encroaching upon the lumen. True. Or ischemia is a functional consequence of atherosclerosis encroaching upon the lumen and causing some sort of flow limitation. I think if we understand atherosclerosis and its characteristics in its totality, I think it will give us much richer data about somebody's risk of future events, about somebody's ischemia, about somebody's ability to respond to medical therapy. And I think there's a whole host of evidence that is emerging to support that claim.
Okay, perfect. Thank you. So one of the questions, which is a very hot topic right now, is machine learning or artificial intelligence. And what do you think this would serve the purpose in the field of cardiac CT?
Yeah, you see so much of this, right, in the lay literature and
everywhere we
AI
go.
versus MD in the New Yorker. And I think it was Jeff Hinton, who's a Google scholar, who said that we should stop training radiologists now because machines will take over.
We're going to lose our jobs.
I think that the machine learning is such a powerful tool, but I think that we should remember that it's just a tool, right? And True. I think it will do things for us that we could never have imagined 10 years ago. And certainly like automated diagnoses and more comprehensive quantification of image findings, it will do that 100%. So for anyone who is not learning machine learning and trying to sort of say, no, that's not going to influence my career, it's definitely going to influence our careers. I think it's just how we harness that information. And to me, I think what's going to happen is, now I'm going to date myself, but when I was a medical student, I used to, after rounds, seeing patients, we would go down to radiology, and the radiologist would point out everything on the image, and that radiologist was the smartest person in the room. And I think what will happen with machine learning is that radiologists and imagers will gather more and more data and be able to integrate all of that data using these machine learning algorithms in a much more insightful fashion, and I think that they will remain the smartest people in the room. So okay. I think the future is bright for radiology, and I think that the machine learning will enhance the field.
Perfect. So our job is safe.
I think so, yeah.
Okay, so last but not the least, I was just told that you came up with the idea first, so this is something for the fellows and residents. So when you came up with this idea, what was your vision for it, and how far do you think we have come right now?
Yeah, I think we've come a long ways, and I think the rationale behind it was I was very fortunate to have met a couple of people early on, Dan Berman and Leslie Shaw, who sort of took me under their wing. This was probably 10, 15 years ago, and they exposed me to things that I wouldn't otherwise be exposed to. Okay. And I thought, I just got lucky to meet some really great, amazing, smart, nice people who cared to work with me. And so I thought, it shouldn't depend on luck. We should have a formal process where people can be exposed to different kinds of opportunities. And so that was sort of the impetus behind FIRST.
Okay, perfect. Thank you very much. Thank you for your time.